So as you know, we're presenting a special symposium of the intersection of regenerative medicine and health span. And the next keynote presentation on the topic, tissue engineering, applicability of different cell types, I'm going to bring up the one and the only, and a person that's still getting mic'd, and the terrific, the director of the Wake Forest Institute for Regenerative Medicine, my esteemed co-chair, along with Joan Shank, the Director of Education, of the Regenerative Medicine Essentials course next door, the Director of the Wake Forest Institute for Regenerative Medicine, Tony Atala. Let's give it up for Tony.
You know, Bernie, I gotta tell you, I love you. You gotta love Bernie, right? You really do. So thank you, Bernie, for everything you've done for the World Stem Cell Summit and all the wonderful organization that you have done for this meeting. There it goes. Okay, so it's great to be with all of you, and I know that I had the pleasure of being at the Core Summit today, and it's just really exciting to see all the talks going on at once, and all the wonderful speakers we've had, and I enjoyed the panels as well. So what I thought I'd do today is really give you an overview of some of our thoughts on these cells for regenerative medicine therapies. So as you know, we're talking about Regen Med, and we're talking about using scaffolds alone, cells alone, cells and scaffolds together, and this whole other bucket we call enabling technologies, where we're doing 3D printing and small molecules and all other kinds of stuff. But in reality, when you're talking about the number one area of what we deal with are the cells. And so I'd like to concentrate a little bit on the cells right now. And three basic areas of cells that I'd like to talk about. And first is the area of undifferentiated cells and other types of factors that actually go into the body. And then I also want to talk about organ-specific differentiated cells. And I want to talk about undifferentiated stem cells that we can actually use. So those are the three areas I'd like to cover real briefly with you today. Okay, so now this is frozen. All right, Bernie, come up here and tell us a joke. Come on up here. Where are you, Bernie? Bernie, we need you to come up here, and why don't you tell everybody a good story while I fix this computer here. And
at the board. I'm sorry, let me see if I can fix this.
there, that's good. Now it's good. Okay, never mind, Bernie, thank you. Sorry, Bernie, but that was good. That was good. I didn't mean it to be a setup, it just worked that way. But, okay, so here we are. Thank you. I got it, thank you. All right, so basically, I was talking about the three things we're going to talk about. Yeah, we're not on the screen, though. Hold on 1 second. We're not on the screen yet. Did you disconnect it? But it's not going up there. Is it this?
No, that's just for the...
Yeah. I think you turned it off, though. You said you had turned it off.
One thing I learned
perfect. Thank you. Yes, sir. I didn't hear a thing he said, so someone's going to have to tell me what he said. All right, so let's talk about, so very quickly, I'm going to try to really catch up with the schedule so we stay on time. So basically, when we're talking about undifferentiated cells and factors, right, we're talking about cord, cells from fat, cells from the bone marrow, perivascular cells, exosomes. All these things have one thing in common. They're going to get inside the body, they're going to do what they're supposed to do, and then they're going to get cleared from the body, right? If you all heard Arnie Kaplan's lecture earlier this week when he talks about MSCs being just basically manufacturing cells, right? And so that's really, I'm not going to go into that because you already heard, I'm sure you probably heard from Arnie and his philosophy about this, but basically these cells are really putting in really, really strong cells for immunomodulation. They really work very well. But one of the things to consider, though, is that these cells are going to be responding differently depending on the patient you treat, right? Because every patient is genetically different, and every patient has different epigenetics. But also, because you're using cells or materials that have limited expansion, you really do have the batch-to-batch variability to worry about. So those are the two major challenges with these cells. They work very well, though. As you know, we had a lot of advances with COVID showing how well these cells did in terms of immunomodulation and anti-inflammatory responses. But we have to keep in mind some of the limitations as well with these cells. I mentioned this yesterday in one of the panels, but one of the major challenges that we have in using cells is to make sure that we go above and beyond the placebo effect. And that is why you've seen a lot of these technologies fail over time, right? You've seen companies like Abbott Vascular and Boston Scientific, and they went after these cells because the phase 1 showed favorable results. But the problem was that once you go after the phase 1, you really have to increase the numbers, and that is when the placebo effect really comes up, right? Because that's when you're doing the controlled studies and the double-blinded trials and everything that the FDA will require. And unfortunately, that's when these technologies tend to drop off. And they tend to drop off because of the placebo effect. That's really what's going on. To the FDA, you have to show that your therapy is better than your control, right? And that is one of the challenges that we're facing in the field. So that is why creating these trials in a well-organized manner with long-term data is critical for the success of our field. So next are the organ-specific differentiated cells. And these are cells that you get from the specific tissue and organ. And we seldom ever talk about these cells because we talk so much about mesenchymal stem cells. But with these organ-specific cells, you can go to things such as muscle or skin and cartilage and kidney, and then you can incorporate those cells back into the native tissue where they will stay, as opposed to the other cells where they leave the body mostly within 24 hours. These cells will stay at that site and provide function possibly long-term. Let me give you a couple of examples of this. Let's look at skeletal muscle injury. So skeletal muscle, of course, is present throughout your whole body, right? And there are major conditions: orthopedic, urologic, otolaryngology. So let me give you some examples of skeletal muscle itself. We started this work back in the early 1990s to actually find the true satellite cell that could expand outside the body into large quantities and would have the properties of a skeletal muscle cell after expansion. So we spent many, many years doing this. In fact, we started aiming for urinary incontinence. We started looking at animal models to make sure that these technologies could work. Major challenge, there was no animal model that you could trust for urinary incontinence. So we had to spend several years building such an animal model. We developed small animal models, large animal models, and finally the release criteria. It took a long time to finally get these cells into patients. So the strategy is you go to the patient, you take a biopsy of the muscle tissue, you isolate the satellite cells, you expand those cells outside the body, and then you place them back into the diseased region of the body. And this is our FDA phase 1 trial for urinary incontinence, showing very nice results for these patients. You can see the pad weight, which means the degree of incontinence before and after therapy, all the way up to 12 months of the trial. We have now expanded that to rotator cuff injury. When patients have rotator injuries in the shoulder, they basically lose muscle strength. So by the time you do the surgery, the patient already has muscle weakness that they typically do not recover. And so what we do here is we take, at the time of surgery, we can take the cells, do the same thing, put them back into the body at the time of the rotator cuff injury, and you can see here that after this is done, these patients regain muscle function in the area, they have increased strength, and they have decreased fatty infiltration and increased muscle to fat ratio, as you see here. So basically showing that we are putting these cells in that site of injury, and what we're seeing is that the cells set up a residence in the native muscle. They start connecting with the other muscle tissue, they start forming new muscle tissue, and they start contracting with the new muscle, and they stay because they're your very own cells, and they go right back where they belong. So we are now starting our third series of patients with this technology for fecal incontinence, which is another major area of need. So one technology, 3 indications, skeletal muscle, using the patient's own cells, where they go back in and they stay long term, and they're functional. So that's one example of these tissue-specific cells. Here's another example with kidney cells. So this is actually work that we also started back in the 1990s. You take the cells, we spent several years figuring out how to get these cells to grow and expand outside the body, because these cells could not be expanded before. So we spent a lot of time looking at the release criteria, cell expansion, growth factor biology, to finally get cells that we could grow and expand reliably. We then were able to place these cells onto devices that we seeded with collagen, and we then implanted these, first in small animals, then in medium animals, then in large animals like cows and steer. This is from our experience in cows and steer, showing that we implanted these kidney structures, they started to form this yellow fluid, which was consistent with dilute urine. If we used it in a non-autologous animal, of course, it would reject, and if you didn't seed it, nothing would happen. When we analyzed the tissue structures, you could see the typical nephron unit, the glomeruli, and below the glomeruli, the proximal tubules, and then the loop of Henle, and then the distal tubules here. I don't know if you can see the pointer. I certainly cannot. But basically, that's on the right. On the middle panel, you're seeing the proximal and distal tubules on the top, the glomeruli on the bottom. On the left panel, you're seeing what happens if we put it into a non-autologous model where it's rejecting. And when we looked at their erythropoietin levels, they were consistent with kidney. When we looked at their vitamin D3 levels, they were also consistent with kidney tissue. We looked at the molecular markers and genes and proteins, they were also consistent with kidney tissue. We published our work. It was highlighted. Nature Biotechnology, successful transplantation of clone cells, because we use clone cells to create these structures. So where are we with this technology? We can now go to a 75-year-old patient with end-stage kidney disease, take a very small biopsy of the kidney, and expand the cells outside the body in very large quantities, just with a needle biopsy. And once those get expanded, they can be used then to treat kidney failure. This is actually in an animal model. In the animal model, you see here the 2 nephron units on the left. You see all the new nephron units on the right after implantation. And this is now in phase 3 clinical trials right here in a company in our backyard called ProKidney. This is a technology where you take a biopsy from the patient, you expand the cells outside the body, you put them right back into the patient, and the phase 1 and phase 2 clinical trials have shown that you can prevent these patients from progressing to dialysis. And so this is now a publicly held company. They went public last summer. It's worth about $2 billion at this point. This is another technology for skin. This is actually a technology that we worked on for the for the Armed Forces Institute for Regenerative Medicine. This is a technology where over 300 patients were treated right here at Wake Forest, where you go to the first-degree burns, no problem, right? Third-degree burns, they're deadly if you don't treat them right. And second-degree burns, if they're deep burns, they're also bad. So this was for deep second-degree burns, and this is where you take a biopsy of the patient, you take those skin cells, and you can spray them right onto the patient. That's now commercially available. All right, so those are basically examples of taking the patient's own cells and put them right back where you need them, where they will take up residence and they're not going to go away, right? They're going to remain where you need them to be. Finally, the third thing I want to talk to you about is actually the third step is undifferentiated cells that are differentiated into specific cell types. So let me give you a few examples of those. This is work that we're currently doing at the Institute. As you know, postmenopausal women or women in their 30s who have not yet reached menopause, they're not very good. Their ovaries really don't make good eggs, right? There's a time limit for making good eggs. And if this is what you see, a human ovary on the left from a donor in the early 20s, and you can see all these eggs, and here's one in the late 30s, and look at the difference. Look at the difference. So that is why it's such a challenge with fertility in the late 30s. So basically, what we wanted to do is look at stem cells from these tissues that we could take that would be undifferentiated cells. And so here we were able to obtain human follicular cells from postmenopausal ovarian stem cells. So these were just basically, we were looking for the stem cell in the ovary. Once we isolated the stem cell from the ovary using specific markers that are used for pluripotency, we then were able to differentiate these cells into granulosa cells, as you see here, which are the supporting cells of the ovary, and we're able to also differentiate it into these theca cells that are the other supporting cells, and we can then characterize those cells, and these cells, as you know, are capable of producing androgens. And then 36 hours post an LH surge, we were able to create these oocytes from these bioengineered stem cells, and these follicles were collected and assessed for their fertilization development competency. And you can see here these follicles that were created from these postmenopausal specimens. And we can then do parthenogenesis to activate the egg division from these cells. And basically, we're now looking at using ICSI procedures, which is intracytoplasmic sperm insertion, to try to move this technology forward. This was all done with human cells. It has not been done implanted in humans yet. But this is an example of undifferentiated cells that we can differentiate, which is different than what I've shown you in terms of cartilage cells or muscle cells, etc. The other area, of course, are stem cells. And we've had lectures from Jean Loring about human embryonic stem cells, from iPS cells. We've had lectures about human embryonic stem cells. We've heard from all kinds of lectures this week. So I'm really not going to repeat those topics again. I'm going to talk about, just to summarize, that we have two different major categories of stem cells. We have embryonic and induced pluripotent stem cells. And these cells, they grow rapidly. They can turn into any cell type. But as you know, they have challenges because they do have the potential to form tumors that, thankfully, this is trying to be solved right now. But they do have the potential to form tumors. And of course, there could be issues with rejection. On the other hand, you have adult stem cells that can come from bone marrow, fat, cord. They don't form tumors. You can use them without rejection if you use them in an autologous manner. But unfortunately, they're very limited in terms of their own lineage, right? Mesenchymal cells can form mesenchymal cells, but they can't form mesoderm or ectoderm. So they're basically, or cord cells can be hematopoietic, but they can't go into other directions, and they have limited growth potential, as we mentioned before, because they do observe Hayflick's limit, right, which is 40 population doublings. So approximately 20 years ago, we thought that perhaps there would be a stem cell present in both the amniotic fluid and the placenta. The amniotic fluid, of course, being the fluid that covers the developing baby, and the placenta being the tissue that envelops both the baby and the fluid in the womb. And so we really went on a fishing expedition. And what we found was that there was one factor. We tried all these different factors, but there was one factor that actually allowed us to isolate this specific stem cell type that we could actually grow in very large quantities outside the body. And the cells, we obtained these, we went over 400 samples from patients from both amniotic fluid and placenta to obtain in all of these a stem cell population. And we were able to show that from all of these, we were able to differentiate these into all three lineages: ectoderm, mesoderm, and endoderm. And like human embryonic and iPS cells, the cells were clonal. That is, one cell would give rise to all three germ layers. And these cells had markers consistent with human embryonic stem cells, like OCT4, which is the most powerful embryonic stem cell marker. But interestingly, it also had markers consistent with adult stem cells. And that's when we knew that we had a different cell type. So when we looked at the stemness of these cells, we were able to show that if you were to look at human embryonic stem cells, which are very, very primitive, and iPS cells, which are right next to it, and you look at adult stem cells, which are on the other whole end of the spectrum, these cells are very closely related in their stemness to human embryonic and iPS cells. Like human embryonic and iPS cells, they would preserve a telomere length. That is, the cells could keep growing and growing. But this was a major difference that surprised us, that unlike human embryonic and iPS cells, these cells would not form the tumors, because they're not as primitive, right? They're pushed more into a developmental pathway already. So the cells can be used in two manners. The cells could be used just like bone marrow stem cells or fat stem cells or other stem cells in terms of their immunomodulation properties. But when you do compare them side by side, they have a much higher anti-inflammatory milieu than stem cells derived from the other cell types, including not just cells but exosomes. They have a much, much higher anti-inflammatory ability. And with these cells, because you are using these cells from the same source, that is, you can just get this, from one specimen, you can use as many cells as you want, you don't have that batch-to-batch variability that you see with other cell types, right? Because you don't have to go donor after donor to get more cells to grow over time. Even though there is good expansion capabilities already, this actually provides you with good expansion. Or, in addition to immunomodulation, like you would use cells like mesenchymal or fat cells, etc., fat, bone marrow, you could use it as a true regenerative medicine approach where you can actually differentiate this cell into different tissue types. Now, for example, we can differentiate these cells into bone. As seen here, you can see upregulation of alkaline phosphatase and osteocalcin and mineralization of these cells when they get exposed to different areas. They can go into a cartilage differentiation pathway. In fact, we have already used these cells for patients with injuries in the knee, where you see good, very, very nice cartilage formation in the area of the deformation. You can see very good functional improvements in these patients. You can also turn these cells into cardiac cells. And this is actually a nice slide because it shows you here. If you look at the very top right, there's SOX2, which is in fact the major stem cell marker. And you can see that within 10 days after differentiation, SOX2 goes down to basically 0. So you're taking the stemness away of the cell when you're differentiating it. And if you look at the second panel on the top, you see cardiac troponin T, and that's going up 1,200-fold at the same time. So as you start to push the cells to a cardiac phenotype, you can see the stemness go away, the differentiation go up. And the cells start to form the typical cardiomyocyte shape, and they start interacting with other cells and beating with the other cells. So they establish mechanical and electrical connections with the heart. You can create endothelial cells that can also grow in large quantities outside the body. These are positive for CD31, P1H12, factor 8, KDR FLIC1. You can turn these cells into liver. And as you know, the terminal differentiation marker for liver is formation of secretion of urea and albumin. And that's exactly what you see when you push these cells to liver phenotype. You see both urea and albumin production. You can then start using these cells for therapy, like here in the lung, where we're basically showing that when you inject the cells, you can actually reverse lung injury. You can also use the cells for kidney injury, where you inject the cells and you can reverse kidney injury. And they have we're using them experimentally for necrotizing enterocolitis, which, as you know, has a high mortality rate of up to 40%. So what we do here is we create this model for a very well accepted model for necrotizing enterocolitis. You can see here the breastfed intestine. You can see here the necrotizing enterocolitis, which is basically a dead intestine, is necrosed. And then you're going to see in the next slide the necrotizing intestine treated with the stem cells, with the amnion stem cells. Here's again the histological view of the breastfed intestine. Here is the necrotizing enterocolitis intestine. And here's the intestine treated with the cells. So you can see histologically the repopulation. We have also used these cells for hemophilia. This is a sheep model of hemophilia that Dr. Chris and Grasa Parada have been working extensively here at the Institute, where we now show that you can actually reverse hemophilia in a sheep model, and as well as other large animal models as well. So where are we with this? We're actually already filing the IND to start proceeding with clinical trials. I'm going to show you now a little bit of a gross picture because it's a wound picture, but this is interesting because this is a patient with a diabetic foot ulcer that remained without healing for over 6 months, And you see it here, and after one injection, within a few weeks, you see this improvement. So it's a very powerful cell. You can do that with other cell types, but what's nice with this is the quickness that this can be accomplished. So this is basically a new stem cell class, which we described a while back. You can get it from the placenta or the amniotic fluid, or both. You can just wait till the baby's born and get it from the afterbirth, which is the placenta. Unlike human embryonic and iPS cells, these cells will not form the tumors. Unlike adult stem cells, these cells will keep growing over time. They're telomerase positive, so we still have cells growing from many, many years ago that they just keep growing. You can just keep expanding them. And unlike adult stem cells, you can direct them into all three lineages: ectoderm, endoderm, and mesoderm, just like human embryonic and iPS cells. And because the cells are clonal, you can have a higher level of a standard when you're going to go to treat patients. Now, no cell is perfect, and neither is this one. And the weakness with this cell is that you do have to work harder to drive it. So, for example, with a human embryonic or an iPS cell, it takes about 10 days to get these cells to liver, to become a liver cell. With the amnion and placenta, it takes about 20 days. So it takes twice the time to do this. But that's also the same feature that does not allow the cells to form the tumors. We published that work in Nature Biotechnology. It's a new stem cell class that we described a while back. And we are now that we have these cells in humans, we are now launching and we're going to be launching actual service to preserve these for patients, for families when babies are born using this specific technology. So to summarize then, what I've tried to do for you today is really give you a broad overview. All cells are good. That's the message, right? It depends who you're treating. It's patient-specific, right? Every cell has their strengths and their weaknesses. And basically, it's going to be like a menu. Which cell will you use for a particular patient? Sometimes it's just easier to use one cell type. Sometimes it's better to use another. There is no bad cell. They're all good cells, but we do have to be very careful about how we do these clinical studies to make sure that the outcomes we are looking for are truly there long term. Thank you for your attention.